Good evening, everyone. Thank you for joining us tonight for yet another Hazelhurst CPD series. And tonight we'll be discussing women's health. My name is Lydia Koenig. I'm CPD Program Officer at Central and Eastern Sydney PHN, and working with us tonight, Bertha Harvey, who is CPD and Events Manager. And before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community, and pay respect to elders past, present and emerging. And I also like to extend that respect to Aboriginal and Torres Strait Islander colleagues joining us tonight. And now I would like to welcome this event's chair, Dr. Christopher Roth. Chris is practicing GP and one of the GP advisors in CPD education for the South region. Thank you, Chris.
Okay. Good evening, everybody. We have a women's health urogynaecology update as tonight's event. And I'd like to introduce the speaker, Dr. Dean Conrad. Dean is an obstetrician, gynaecologist, and minimally invasive pelvic surgeon. He's a staff specialist at the Sutherland Hospital with admitting rights at Carina, St George and Hurstville Private. Dean provides pregnancy care, fertility support, and pelvic floor health services. He specialises in advanced minimally invasive pelvic surgery. Dean is dedicated to treating fertility challenges and pelvic floor dysfunction. He has a particular interest in complex surgery, including advanced endometriosis, difficult hysterectomies, large fibroid removal, and non-mesh treatments for urinary incontinence and prolapse, delivering holistic, patient-centered care tailored to each individual's needs. So without further ado, I'd like to hand over to Dean, who will give us our presentation tonight, and we'll have a bit of time for some questions at the end of the presentation. Thank you, Dean.
All right, thanks so much, Chris. I'm really happy to be here to have a chat to you all about urogynaecology issues in GP. Thanks for the kind introduction. That little QR code has the link to my website if anyone wants to contact me or know a bit about what I do or chat to me on social. All the info is there, so feel free to take a little screenshot and contact me anytime. All right, so today we're going to be talking about bladder issues. Chris has asked me to talk about some of the common the clinical presentation and causes, including incontinence and overactive bladder as two separate things, and by popular request, something on recurrent UTIs. We're going to talk about the different types of incontinence, when to refer for investigations and specialists, and talk about some of the evidence-based management strategies and understand when the need to refer on. There'll be time for questions at the end, but feel free to jump in any time with Q&A if anything is important. Let's talk a bit about background. Urinary incontinence is super common undertreated. I want to highlight this as something that's incredibly common in affecting up to 50% of adult women, much more so in patients that have had children before. But importantly, only 1 in 4 patients actually seek help in the community. So a lot of people that are suffering in silence are either too embarrassed to seek help or unaware that there's help available. Although it's not usually, very rarely, but not usually dangerous or deadly, it is a problem that has significant impacts on people. It's a big impact on quality of life, can make social isolation, significant impacts, work impairment, depression, anxiety, there's sexual dysfunction, now the fear of incontinence during either penetration or orgasm, and that's both bowel and bladder. There's a lot of morbidity associated with that, falls and fractures in the elderly, and just perineal infections and hygiene, and it can increase caregiver burden. I've got patients of all ages, shapes and sizes, and it's never too late and you're never too old to improve. So it's always something we can do to help out. Now, before we go into abnormal bladder function, I think it's all important that we speak in the same language and talk about what is normal bladder function. So a normal bladder should hold about 500 mils of urine and feel the sensation to need to empty at around 200 or 300 mils. We should empty about 4 to 8 times a day, so around every 3 to 4 hours. When you do empty, you should empty completely in a continuous stream without straining and empty completely. And when you're asleep, the bladder can wake you up when it's full, but give you enough time to go to the toilet. Importantly, a normal bladder does not leak. So let's now talk about what abnormal bladder function is. So if it can't hold urine, or you feel the urge to pass urine earlier, we call that an urgency sensation, or a sudden compelling desire to pass urine, which is difficult to infer. If we're going to the toilet more frequently than every 3 to 4 hours, we've got frequency. We define that as around every 2 hours. If emptying is abnormal, we call that voiding dysfunction, or a difficulty in passing urine. And overnight, if you have to wake up several times, more than once per night, we call that nocturia. So note, though, that each decade, kind of over the age of 70, it's normal to wake up once or more per night, and it can increase in time. And we'll talk about it later, but there's a difference between nocturia and nocturnal polyuria, and we'll talk about that a little bit later. So let's talk about some of the different types of incontinence. I think this little diagram, although a simple and basic one, really helps solidify the types of incontinence. First of all, we have our urgency urinary incontinence, and I'd like to direct you to the middle-aged postmenopausal lady, hands in the air, freaking out, seeing the toilet sign, running to the toilet, leaking along the way. It's our typical kind of presentation. This is that involuntary loss of urine associated with an urge to pass urine. Then we have our stress incontinence, and I'd like to focus here on this image in the top here, with a patient holding a baby and hysterically laughing. It's not emotional stress, as some of my medical students seem to think, but it's physical stress. An involuntary loss of urine associated with that increased intradermal pressure. Running, jumping, sneezing, coughing, laughing, vomiting, any kind of increased pressure. Mixed incontinence is a combination of the two. Overflow incontinence is typically what we see in our male patients, or our prostatism. Whoops, sorry. It is also something that happens in women. We'll talk about that as well, but that's our typical, that bladder outlet is unable to pass, need a certain volume and amount to overcome the pressure, and then we leak because of that. And finally, that's functional incontinence. Need to pass urine, but unable to pass urine because of a functional impairment to get to the toilet on time. So we're going to do a bit of epidemiology, which is, a little boring. So let's make it a bit interesting. Let's do a bit of a multiple choice question to figure out what you guys think about this. And I think there's a bit of a Q&A function, but it doesn't really matter. Have a think about what you think it is. Whack in a letter into the Q&A function and tell me. We'll see if we got a bit of people agreeing on what the answer could be. So let's start with the most common type of urinary incontinence. Of those 5 types, which type do you think is the most common? Is it our urge, stress, bit of both, overflow, or functional? Give a bit of time to think about it, but I'll probably just move on. If you said mixed incontinence, you'd be 100% right. It's really important to understand that actually most women with incontinence have a bit of both. So it's very important to kind of work out what they're experiencing and how things, what their symptoms are and which symptoms are predominant. Up to 50% of patients of adult women in Australia have some kind of incontinence. Let's talk about the certain types. If we're talking about urgency urinary incontinence, what do you think the age of the peak incidence is for urge incontinence? Is it our younger women, 35 to 44, or as we get through the ages, is it more towards the older, postmenopausal, and particularly above 75 and over? Which age group do we feel that urgency, specifically isolated urgency incontinence, is more likely to affect? You have a bit of think about that, and if you said the answer was D, you'd be correct. I want to really, make this quite clear that the urge symptoms, the bladder's ability to hold and to pass more frequently, just worsens as we get older, and the peak incidence is in our elderly age group over 75. Well, what about stress incontinence? What about the physical exertion leaking with increased abdominal pressure? Is it our younger ladies? Is it our older populations? Is it somewhere in between? What are we thinking? Now, if you said 35 to 44, you'd be 100% right. And this is my pet area of interest that I'm really focused on, because stress incontinence is a condition that affects young, healthy women. This is the peak time that it happens soon after childbirth. A lot of women will have had one or two vaginal births, have some problems, and experience stress incontinence at this time. Often they don't seek help about at this time, or they don't do anything about it because they're too busy looking after kids. But this is the time when it's most common to get symptoms. So this is a disease of young women, and it's particularly important when we think about mesh products. Thinking about the long-term consequences of poorly placed products in younger women and what kind of impact it's going to have on their life for the next 40 or 50 years. So very, very want to labor that point, a condition of young women. So let's now jump into the GP perspective and talk about the assessment of incontinence. We're going to talk about that with this talk, and we're going to go through the history, some the findings, some investigations, and some referral things to chat about. First of all, with the history. Taking history for stress for your bladder function is difficult. I see my patients usually a 45-minute time frame, and it's hard to get through everything that we need to get through. So you guys would be, strapped for time, seeing so many patients and so many different things. It's not an easy history to take. I really like the Australian Pelvic Floor Questionnaire. First of all, it's an Australian-based questionnaire. It's a validated questionnaire that we use for our audit and for some of our research databases, and it goes through 42 questions, which that's a lot of questions, but it goes in detail about the bladder, all those things we talked about, the bowel function, which is vital, prolapse sensation, which often go with bladder, and sexual function is an important part to talk about. One thing it doesn't do is talk about a severity so much, and I always like to do this mainly with a bother score. Something I ask all my patients is, how much does it bother you? Tell me from 0 being no bother, 10 being a severe bother, what do you rate this? And sometimes that's the way to really identify the effect on them. With someone leaking once a week, they might not be bothered by that. Other people be incredibly bothered. So telling how many pads or what's happening is not really a good way to assess severity in my mind. I want to know how much it affects them. It's also key to then know the risk factors, and we'll go through these a bit more when we dive into the different types of incontinence, because they're going to be different types, or they're all relevant, but there's going to be certain types of risk factors that are more prominent in different types of incontinence. And we'll talk about this in a bit more detail later. Medications are key. There's very easy changes to medications we can take, with the classic one being, patients with nocturia taking a diuretic at night. You just change it in the morning and their nocturia is gone. Some medications can have different effects on the bladder for different causes. Your diuretics obviously can increase urine production, but there's other medications, including antihistamines, any muscle relaxants or narcotics, that can relax the bladder to the point that you can get overflow incontinence. Some of the alpha-adrenergic blockers like methyl-dopa can impact the urethral tone, and simply cough as a side effect of some of the ACE inhibitors and angiotensin receptor blockers can cause issues relating to leakage. So always think about the medications and what they're on, particularly about the anticholinergic burden. Examination is vital. I do a BMI check for my patients because it's a big risk factor for both incontinence and prolapse, and for recurrence after surgery. So I always like to be focusing on that and understanding their dexterity, mainly due to risks of needing to self-catheterize, because that's sometimes a complication of some of the continence procedures. I always do an abdominal pelvic exam. I feel their bladder and kidneys, because you don't want to miss that retention and that pain or enlarged bladder or kidneys. The vulva can be an important place to look for any dermatitis, especially in patients that are elderly, wearing pads but not changing them frequently. Atrophic changes are terribly common, and I love using some topical estrogen cream. We'll talk about that a bit more. Cough test, it's a really simple thing. Just ask them to cough to see if they're leaking. A tip though, always say, I've got a tissue here, have a tissue there, show them the tissue, say, don't worry if you leak, because most people will try and not leak. And if you say, I've got a tissue here, and they feel more comfortable to actually cough, then you'll get it more often. We'll talk about POPQs, or a pelvic organ prolapse questionnaire. This is the picture on the side here. It looks very complex, and it's not that complex once you understand it, but really, all I really want to know is how far is the leading edge of either the cervix, bladder, or bowel descending to the opening of the vagina. So in Valsalva, how far is it? How close is it to the opening is really enough of indication to work out what's going on. And then I can look in a bit more detail about what components are contributing to that prolapse. Assessing the pelvic floor is a good idea. Get them to squeeze your finger. Tell them you're trying to stop yourself from passing urine or passing bowels. I'll occasionally do a rectal exam, both for, fecal incontinence, and very rarely do a neuro exam if I'm worried about a neurological cause for those symptoms by taking the sensory sensation of the sacral cord, or the sacral nerve plexus, and the perinomical, the motor reflexes of the anal sphincter. When it comes to investigations, always consider an MSU. It's a very easy thing to do that can actually cure people. So if you find an infection, their incontinence can be all to do with that and can be cured. I really like bladder diaries. They're something that I use quite frequently. A lot of the physios I work with are great and do them as well. And can be a very useful way of investigating and assessing what's going on. We'll talk about that as well. Post-void residuals are very easy to do. If you do have access to ultrasound or even just an in-out catheter, ask them to pass urine, look how much is left inside, and it's quite easy to diagnose. Imaging is very rare. I only really do that if we're really worried about suspected masses, so very rarely we do imaging. And urodynamics is something that I do as a part of my workup for procedures, and we'll talk about that in a bit more detail. And yeah, the cartoon on the right about bats being incontinent, that wouldn't be a pleasant thing with a bat, but I'm sure they'd have no prolapse. Hanging upside down is a good treatment for prolapse. Let's talk about some of the red flags, or when to be concerned, or when to really refer on to the specialist. Anything abrupt onset of urinary symptoms is weird. Generally, people will say that, oh, after my kids, things were a little bit of a problem, kind of got worse with time, the menopause hit and things deteriorated from there, and I've been putting up with this for a while and now I'm over it. That's usually the story that we get. Very weird to say that, it was fine and then this morning I couldn't pass urine. That's a weird thing, or something very abrupt. Not normal. Think of neurological issues and refer on. Pelvic pain is weird as well. That's a red flag with any kind of urinary incontinence or even any kind of prolapse sensation. Pain is not normal. Think about retention, especially if it's relieved by voiding. Hematuria, especially without infection, even with infection, it's not good, but thinking about stones or cancer. If the diagnosis is unclear or symptoms are mixed, it's not a worrying thing, but I think sometimes it's better to get some more information before starting on therapies, even though it's totally fine to start on some conservative treatments in the first instance. If patients aren't improving with the conservative therapies, physiotherapy, anticholinergics, I think that's another reason to refer on. Severe pelvic organ prolapse or prolapse beyond the introitus. This is something that it should be reviewed because it can have impacts on the body, but this is something that people can be suffering with for a long time. I remember seeing a patient that had one of the worst procedures I've seen, putting up with it for like 10 years. And I said, why didn't you see me earlier? And he said, oh, I thought it was cancer. And that didn't really make sense to me at the time, but she thought it was cancer, ended up not dying from it, and then thought, maybe I should get someone to look at this now. So people put up with things and don't want to see doctors, and so they'll put up with a lot for a long time. Any history of previous pelvic surgery, it complicates the diagnosis and complicates the management. So it's a bit hard to manage this without very detailed investigations. Any kind of voiding dysfunction I do worry about, mainly because of the impact on the renal tract. And remember, the one really dangerous thing in continence is retention, damaging the kidneys, causing renal failure and potentially death. So always worry about that. Anything suspected neurogenic, any kind of, we think a spinal cord lesion or some kind of neurogenic cause is another thing to be wary of. This is a bladder diary. It's a pretty simple thing to ask people to do. It's annoying for people to do, but it tells us a lot of information. I get them to do that over 2 days. I get them to write down the time, what urgency sensation they feel, and I've got little instructions on the back of the sheet if they've leaked or not, and the volume of urine they've passed, or whether they've passed bowel motions. To check the volume, you can go to the chemist and buy a fancy witch's hat that sticks in the toilet, or you can just go to the dollar store and get a jug and put it in the toilet, and they can see how much they're emptying. Also want to record what they're drinking, what type of fluid, and how much it is. Also want to know when they went to sleep, when they woke up, so we know whether they're waking up overnight multiple times or whether they're just, not yet to go to sleep. This sometimes is enough to diagnose people with problems. You'll see this, and first of all, you'll calculate how much they're drinking, and they're drinking 4 liters. And if I drank 4 liters, I'd be also running the toilet every half hour and finding it hard to sleep through the night. Sometimes simple as you're drinking too much, cut it down. Other times you look at it and you'll think you're drinking 3 cans of Coke, a coffee, and a glass of wine. And that's not healthy fluid habits. Caffeine is a potent bladder stimulant, and you want to be changing that up. So the simple things to see. You also want to see when so I was talking about the nocturia before, if they're passing lots of urine overnight, it could be nocturnal polyuria. So they're passing more than a third of their total daily urine production overnight. It could be an issue of urine production being too great overnight rather than an actual bladder problem, rather than actual bladder sensation problem. So it can be useful to delineate what is actual nocturia versus what's actually urine production issue, which could be due to congestive cardiac failure that happens more at night time. So that can be very useful to delineate what's going on. Urodynamics is something that I really like to do. I don't do it routinely. I usually always try some treatment options beforehand, but I do it if there's kind of uncertainty, if the initial therapies aren't working, or if patients require surgery. That's the main reason why we'll use it, because it does really guide what surgery we do for them. It can guide whether they can get away without a mesh surgery or whether the mesh is the thing they require. It tells us a lot about how patients store urine, how patients fill up their bladder, and how they empty, and how they're going to respond and what the causes are. And we'll talk a little bit about that later on. This is an example of a reading, which I won't go into. I think that probably doesn't interest you too much, but it's reading the pressures generated by the bladder and the bowel and what is purely bladder pressures. Let's now go into the management of the two main ones, which is the urge and the stress incontinence. Now, I feel that key with management is to educate patients. And this is a little picture that I draw quite often when I'm talking about the symptoms. First of all, with the urgency of incontinence, that's that frequency, urgency, nocturia. I usually draw a picture like this, and I say that the bladder is a bag of muscle, right? And that muscle squeezes in to make the urine pass. And sometimes that muscle squeezes in when it shouldn't, and you leak because of it. That's a detrusor muscle overactivity. Now, with stress incontinence is completely different. This is where that increased pressure, laughing, coughing, sneezing, or whatever. And I draw arrows from above. Laughing, coughing, sneezing, jumping, running. The pressure that our body puts in the bladder overcomes the support of the urethra, and we leak because of it. And really, we've got to lift and support the urethra in order to prevent you from leaking. Two completely different causes, and sometimes they'll have both of those types, but it's important to distinguish between them. And patients really need to understand why they're different, because the management is different. So let's talk a bit more about urgency, and that's that involuntary loss of urine associated with that urgency, or difficult to defer urine when you get that sensation. And I want to focus, because Christy asked me in our learning outcomes to talk about detrusor overactivity. And this is a really key point, because you can have what we call a dry overactive bladder, right? And this is a danger of being quite quick in your history taking, because you can say, do you leak urine? And they'll say, no, and you move on. However, they might not be able to leave the house because of fear of wetting themselves. They may be passing urine every half an hour because they can't hold any further. They might be unable to sleep properly because they have to wake up every hour to pass urine. So you can have significant impacts and significant troubles and issues in your life with your bladder without necessarily leakage. So it's important to explore with more detailed questions. And some questions are, how often we go during the day? Asking people if they have frequency, they don't really understand what that means. So just be a bit more clear and layman's terms about it. Do you have problems getting to the bathroom on time? How many times do you have to get out of bed to pass urine? Common things, situations. The keys in the front door, that's a stimulus for a lot of detrusor overactivity. The sound of running water, classic one. Sitting to standing, or the increased thermal pressure. I had a patient that with the sound of a can of a Coke opening would cause it to leak. So seeing what kind of links there are to the detrusor muscle wanting to contract. Asking about the stream, it's hard to say voiding dysfunction. So do you feel like your stream is not particularly strong? Do you feel like it empties completely? Do you feel like there's a little bit left inside that dribbles when you finish? So sometimes it's hard to really get to the right questions, but it's important to do it well. Pathophysiology of urgency incontinence, we don't really know. It's that inappropriate contraction of the muscle. It's largely idiopathic, related to aging, and that's why as we get older, things get worse. There are some kind of neurogenic pathways, but really it's quite complicated and hard to understand. But bladder irritation from infection, stones, tumor can cause it. When it comes to risk factors, age is a big one, specifically age beyond the menopause, because low estrogen does impact the way the bladder functions. Genetics is a big role for this, with a family history being significant, and often patients have troubles with bedwetting and holding on when they were younger, and worsens with age. Always think about the medical conditions: diabetes, stroke, depression, medications, diuretics, caffeine, and previous surgery, radiotherapy can damage the bladder and damage the links between the brain and the bladder. So let's talk about the treatment. I always like to talk about lifestyle measures because these are really important. And I quite like this cartoon with this magician coffee doing their first trick, diuretic exam, and the bladder just empties. And then now for trick number 2, the bowels. Caffeine is a stimulant, is a bladder stimulant, it's a bowel stimulant, it's a diuretic, and really can impact the bladder and the bowels. I know myself, I was at the clinic today and someone brought me a can of Coke. And I was like, yeah, I'll have this drink. And then I was going to the toilet super frequently afterwards. And you can tell yourself when you have too much caffeine, your bladder gets suffering. Weight is a big factor. Fluid intake, as we talked, caffeine, alcohol, release of air, and bowel function is important. Bowel and bladder are linked often. When one doesn't work, the other often follows. So these are my danger zones. Caffeine beverages, especially the artificial sweetener, is actually not as good. Alcohol, chocolate, unfortunately, don't want to limit people from having chocolate if it makes rather like urine maybe. But think about limiting these things, especially that espresso martini, caffeine, alcohol, the double whammy, trying to limit them. Bladder training. This is something that I really focus on because we can learn and unlearn good and bad habits. The bladder training, what we usually traditionally teach, is really quite disruptive. Usually it's saying, all right, set an alarm, go to the toilet every hour. Usually you base that based on their bladder diary and seeing how frequently they pass and kind of do what the shortest impulse is, and do that for a week. Then the next week, do it every hour and a half, and then every 2 hours. But that's really challenging for patients to do if they're working and got a life. It's nearly impossible. What I like to do really is say, if you need to go, look at your watch. If you went to the toilet more than 2 hours ago, that's okay. You can probably go to the toilet. But if it was less than 2 hours ago, that's not normal. The first thing I say is to sit down. Sitting down removes that gravity and kind of reduces that impulse. The worst thing you can do is stand up and start running to the toilet. Sit down, contract your pelvic floor. Sometimes people say to scrunch toes because it aggravates the tibial nerve, which has some evidence about deferring urge, but contract the pelvic floor is more reliable. Distract yourself, count backwards from 100 by 7 is a good way of doing that. And often the urge will increase and then slowly settle away. And then if you're at home and you're pretty comfortable that you know where the toilet is, you can wait for the next urge and see how far you can push it. Or if you're out and you need a toilet, you can then go to the toilet. So this is a really good way of managing bladder symptoms, urgency symptoms. If that doesn't work, or it does work, we want to help more, this is where the pharmacological agents come into it. And the 4 main areas that I use and the most relevant ones are, first of all, anticholinergics. So we've got our non-selective ones and our selective ones, and I'll talk about them. We'll get our newer beta-3 agonists and then our tricyclic antidepressants, and I'll talk about them. First of all, the non-selective anticholinergics. These are the ditrizatol or oxybutynin, which also comes in a patch form. They work well, they're great, but they cross the blood-brain barrier and they can cause quite a bit of side effects, especially in the oral tablets. Dry mouth, constipation, drowsiness, and I worry about the dementia risk, especially in the elderly patients, and a lot of patients are also worried about that. Contraindications, they are there, especially acute angle glaucoma can be quite dangerous for that, so you want to just watch out. It's cheap though, and it can work really well. So in patients that really need it, it can work really well. Technically, Oxytrol, which the patch, works better, but you're not supposed to use it on the PVS unless they've failed the oral version, which is a bit harsh, I find, but that's technically what I'm supposed to tell you. When it comes to the the selective anticholinergics, these are usually what I prefer, my first line for patients that can afford it. They are more expensive. $80 a month is more than it usually is. I think it's less than that, but it's something more expensive. You're not supposed to be able to half a 10 milligram tablets. They'll tell you not to, but I've got patients that do. It's once daily dosing rather than the twice daily of the oxybutynin, or the Oxytrol rather. But they're the same contraindications and they can have the same side effects. It's important to talk about the anticholinergics and the cognitive decline. There's a lot of chat about that and about what to do. Yes, there is associated risks with increased anticholinergic burden and cognitive decline. That risk is more pronounced in patients who use it for longer, higher doses, and the non-selective ones, and in the older population. I try and use selective anticholinergics. I try to keep the dose low and short, use it with bladder training, and try and take them off after 6 or definitely after 12 months. And there is the option of the beta-3 agonist, and we'll talk about that. But also think about the polypharmacy and the other anticholinergic burden, like antihistamines and antipsychotics and so forth. Beta-3 adrenergic receptor agonists are something I'm using more of. They are still very expensive. They don't have the same side effects. They're completely different pathways. They're not anticholinergics, but they can increase the blood pressure. So in patients with well-controlled blood pressure on a single agent, I will still use it, but I'll get them to check the blood pressure after 6 weeks of trialing it with yourself. And if blood pressure is fine, the bladder is good, we keep them on it. We can increase the dose, but again, monitoring the blood pressure over that time. And finally, the tricyclic antidepressants. It's a low-dose tofranil, mostly used for the nocturia. It's a lower dose than for depression, can have side effects, but it's pretty well tolerated and can work quite well. Combination pharmacotherapy, I do often use because sometimes for patients who are difficult treatments, we might need to do so. And it's okay to combine them, but do so in caution. I also think it's important to have realistic expectations. We don't need to cure, and it's not necessarily a cure, but we want to get them functional. We want to get their bother score down. That's why I like their bother score. They first come to see me, it's 9 out of 10. After a while, it's 4 out of 10. That's pretty good. You know, we want to get them so they're functional. And always don't forget topical estrogen. I find that topical estrogen really helps bladder function and can help be one part of a bigger management plan. Other treatments, which I won't go into, Botox injections, sacral nerve modulator, tibial nerve stimulation, cystodystension, which is mentioned here, and augmentation, but this is a bit beyond the scope and very rarely we'll use these treatments. Now let's get on to stress incontinence. This is the area of interest that I'm particularly interested in, being a minimally invasive surgeon, and we'll talk a bit about that. The thing that I like to focus on when it comes to this is that we need to know the pathophysiology of why they're having stress incontinence. There's two main causes. One is a urethral prolapse. That's typically the damage from childbirth, and the urethra is just, as I say, flopping in the wind, there's no support. The other is an intrinsic sphincter deficiency, where there's support to the urethra, but the muscle of the sphincter is damaged. And it's important to know the different types because they can determine which kind of procedures they would benefit from, including mesh versus non-mesh. The big risk factors of this are the pregnancy and the mode of delivery. Note that cesarean sections are somewhat protective, but being pregnant itself and having pressure in your pelvic floor for 9 months or whatever it is a potential impact on your pelvic floor and can cause incontinence just with that. So it's important to know that just being pregnant can impact things. Mode delivery, though, is definitely associated with worsening outcomes, specifically vaginal births, specifically the number of vaginal births, bigger babies, and forceps deliveries. These are the risks, and usually you will see them having first child, difficult delivery, big baby, forceps delivery, and I had symptoms since then. Patients with increased abdominal pressure, our obesity patients are quite difficult because their outcomes for surgery aren't as good. Constipation and straining needs to be managed. Coughing due to whatever, smoking, side effects, and lifting heavy objects. Some of my most challenging patients are my power lifter patients. Some patients that really fit, love lifting weights, and it's just not good for your pelvic floor to lift these heavy weights, but you can't tell them to stop doing it. To diagnose it, it's very easy. Get them to cough and see if they leak. NICE guidelines do say that if they've got the UK guidelines say if they've got isolated stress incontinence with no urgency symptoms, you don't need urodynamics prior to offering a surgery. But I really like urodynamics, especially when you're using mesh procedures, to make sure you're using the right procedure for patients. I do want to focus on a rare, but it's a condition that we see called the cough-induced detrusor contraction. You cough, the detrusor muscle spasms, and you leak. Usually you'll get other symptoms of urgency with that, but you can get what looks like stress incontinence that is urgency incontinence. So that's what we talk about the bladder being an unreliable witness. That's a classic situation. Lifestyle changes, similar as before, weight, smoking, constipation, important. Pelvic floor physio, we're very lucky in our area of Sydney, where we are in southeastern Sydney. There are heaps of physios that are excellent at what they do, and essentially everyone that I see especially before surgery, will get physio. I'm very happy for GPs to refer to physios first before coming to see me, totally appropriate. And often they're cured completely. And if not, they're usually significantly improved just from physio alone. And I think it also does help the outcomes or longevity from surgery. It's important, though, that they do it with a physio. Sometimes they'll say, I'm doing my exercises, and I'll say, okay, show me. And I get them to show me, and they're bearing down. They're doing the opposite of contracting the pelvic floor. They're making it worse. So they're doing all this effort to try and fix things, and their effort is actually worsening things. So I think it's really important to do it with a professional, even just a couple of sessions. This is a little video of a educational pelvic floor that I hope the video works with sound. Let me know if not.
Good morning. Start your day with some pelvic floor exercises. Imagine you're lifting your pelvic floor up and relax. Now you can tell everyone you've already worked out today. So follow me and I'll show you where you can do your pelvic floor exercises throughout the day. Now is the perfect time to do some pelvic floor exercises. Suck it in with me now. Ready? Suck in and relax. No one even knows we're doing them. Ha! Still nothing. Time for some more pelvic floor exercises. Imagine you're holding something up your and you're squeezing it. Ready? And squeeze and relax. Do them when you're waiting for a coffee. At least this is the only thing that's leaking. It's time for some pelvic floor exercises. Imagine you're holding in a wee. 3, 2, 1, and hold. And relax. You can even do them when you're picking up the kids.
Who are you?
Oh! Last pelvic floor exercise for the day. Tense you, like you're watching a scary bit. Tense and relax. So you can see there's a lot of times throughout the day where you can be doing your pelvic floor exercises. The more you do, the fitter you are down there. Go to the website for more information.
So I really like that video because it kind of highlights, that don't take time out of your day to do it. Just do it when you're doing mundane, boring stuff. I remember once I was working in a country area and I said, hey, just when you're at the traffic lights, just do them when you stop in the car. I forgot there wasn't any traffic lights in town. But the point is, whenever something mundane that you're doing, brushing your teeth, waiting in line, doing something, you can do them at the same time. So rather than take time out of your day, make it a part of your day. Pelvic floor physios have lots of fun things. They've got vaginal weights that they can use. There's even some feedback where you can squeeze your pelvic floor and you can see on your phone how good you're doing. And there's the Emsella chair, which is a kind of electric shock therapy to the perineum, which can contract the pelvic floor. I think it's okay for patients that are unable to contract their pelvic floor at all. But once they can contract your pelvic floor, it's just an expensive way to do pelvic floor contractions, I think. So, not a bad thing to consider, but it's quite expensive, and I think better off just doing them yourself. There are some continence pessaries, unfortunately named ring with knob, but can be inserted for patients either continuously or for my young patients that are pregnant and just don't want to have surgery, or if they're very active and only get leakage when they're playing netball or soccer, they just put their shin pads on, put their pessary in, and this is part of the process of getting ready for the game. So a very convenient thing for some people to use. Let's talk about mesh. The midriffal slings or the mesh slings are still the most common form of surgery for stress incontinence in Australia. They're effective and safe with good effectiveness and over long-term data with very low rates of problems. Branscog or our college supports the use of them as well as the risk and appropriately trained. But there's a lot of mesh controversy with a lot of patients hearing about mesh controversy. And I want to show you now an excerpt of Darren Hinch, who you may know, talking at the Australian Senate inquiry in 2018, I believe it is.
Is mesh, transvaginal mesh. For about 20 years, this plastic or polypropylene mesh has been permanently embedded as postnatal hammocks, slings, netting for prolapsed organs and incontinence. But it gets worse. Over time, this harmless plastic, harmless, harmless plastic netting can become brittle and start to break away in shards and splinters. They start to float around the body, causing inflammation and excruciating pain. So no wonder these slings have been called a torture device. There have been cases where a splinter has pierced a woman's vaginal wall and injured her partner during intercourse. So no wonder some of these mesh products have been totally banned in Scotland. No wonder there are nearly 100,000 lawsuits pending in the United States over mesh. And because no Australian surgeons are qualified to attempt total removals, some Australian women have taken out loans or increased their mortgage to cover the $35,000 to $40,000 costs of having the operation overseas in the United States. Now, I've met and I've talked to a number of women from all over Australia who have suffered interminable pain and physical and mental breakdowns because of these mesh implants. Some have thought that suicide was the only solution. Having first been told there's only a 1% chance of an adverse reaction, they have since been treated like mushrooms, kept in the dark and fed bullshit by doctors, hospital administrators, the drug companies and even the TGA.
So when you're hearing this kind of rhetoric, it's hard to often convince patients to have these mesh products. You know, it's still in the UK, it's banned. In New Zealand, it's banned. In Australia, it's fine, and the rest of the world, it's now fine. Because we know better that actually it is quite good to use specifically for incontinence, but the vaginal mesh for prolapse is the problem one. So there's some complications like any kind of surgery, but the risk of erosion is low. It is 1%. The problem is if it does happen, you do get pain, it's very hard to manage because the mesh gets reincorporated into the body and it's difficult to remove. So it works very well, very low risks, but for those patients that do have the issues, it's a challenge. Nevertheless, the Australian Safety and Quality in Healthcare recommended the mid-rectal sling as the #1 choice for the management of stress incontinence still. And the alternatives here, we can see here the bulking agent, copper suspension and sling. The alternative that I really like and I'm doing a lot of now is the copper suspension. This is called the Birch copper suspension. It was the gold standard treatment for stress incontinence for 50 years. It was first started in 1961 and was done by a laparotomy, so quite a morbid procedure. In the 90s, Australia was leading the charge in doing the laparoscopic approach using a keyhole incisions, but it was a challenging procedure, difficult to do the suturing in that tight retropubic space, and it was lacking long-term data, but short-term was quite good. The robot, I think, is going to make a big difference from this. And this is just a paper that I published during my fellowship in Ranscock about long-term outcomes from our case series, which were very, very good. The robot, however, I think is going to improve things. Here's a little snippet of me practicing one of the robots and me trying to convince my sister, that's my nephew there, that we're not playing video games, we're just practicing for surgery. I'm not sure how well I managed to convince her, but here's a little snippet, I don't know if this interests you, of operating on the robot. This is the Da Vinci robotic platform. I can use 3 arms, I can traction on tissue and get spaces. This is the retropubic space, that's the bladder filling up, and I'm on the anterior abdominal wall here. So I'm finding that space between the bladder and the pubic bone. You can see here it's a nice bloodless space. You can get really good traction, really good vision, getting right in the space, getting nice and close. I can see better than the screen shows because we've got 3D imaging, and get right up to where I need to be and find the pubic bone and the Cooper's ligament and seek out where I need to place the sutures. Once I've got that space, here we go, getting onto the pubic bone and the Cooper's ligament, I can dissect out either side of the bladder. Here, that's the bladder in the midline. That's a vaginal finger, lifting up the periurethral tissue of the vagina for me to put my series of sutures. And you can see here, when you've got the robot, you can load that needle in any direction you want, up and down, side to side, going through the pubic bone into the pelvic floor, the pelvic tissue, and then keep going. So it's really, I think, is going to make this much easier. The problem is with access and cost. It's still more expensive, and unfortunately, a lot of procedures, especially in women's health, is poorly remunerated for the hospital and health funds. And I think it's just about another example of gender inequality when it comes to healthcare. But hopefully watch this space. I can see it's already been an hour long we're doing this, so I'm just going to carry on. This is another one for the Hugo system, another system I'm using, but same kind of thing. I won't keep on going here because it's the same thing, but this is an example of the pictures comparing the birch on the left with the sling on the right. So you can see a similar way of achieving that lift. The other treatments, slings, lethal bulking agents, there are actually over 150 types of surgeries described. I focus on just a couple to make sure they're really good, but for patients I think that might need other things, I do have my urology colleagues that will do them for me. Mixed incontinence is tricky, as we know that's the most common, and you have to think about what's the predominant. Always start with conservative, think about lifestyle, pelvic floor, bladder training, and treat the predominant symptom. Most people will have one that's predominant, especially if it's urgency. Always start with medication, see how they go. The problem with surgery is that you can worsen underlying urgency, and this is where I find urodynamics helpful to guide on that. Overflowing continence, that's that prostatism classic. In women, it's usually from outlet obstruction, often due to things like fibroids or a retroverted uterus, especially in early pregnancy. Classic time that people with a retroverted uterus first identify they've got retroverted uterus because they can't pass urine, and very advanced prolapse. Sometimes that prolapse can kink the urethra and make it difficult to pass urine until it's very full. You can get neurogenic bladder where you just get underactivity of the detrusor, so you don't get that because that's why it's quite complex. That your bladder has to contract and your urethra has to relax for things to happen. If that process is not working, then you can get this damage. That's some kind of nerve damage that can occur. Treatments: relieve the obstruction. You can simply dilate the ureter, sort out the myomectomy, repair the cystocele. Intermittent self-catheterization will fix it, but obviously an annoying thing for people to do. You can do some double voiding, which I really like, just kind of voiding once, standing up, sitting down, and voiding again can make a big difference for people. And the bowels, always think the bowels. If they're constipated, they'll often have voiding dysfunction. Once the bowels are no longer constipated, the voiding works better. Quickly on some recurrent UTIs. Definition is not very many. You can have just 2 in 6 months or 3 in 12 months and have the definition of recurrent UTIs. Common risk factors: think estrogen, low estrogen, atopic vaginitis, a very common one. Sex, another common one. Any kind of incomplete bladder emptying from voiding dysfunction, prolapse, and bowel dysfunction. Remember, a lot of the causes of the incontinent of the UTI are from bowel pathogens. Any kind of immunosuppressive diabetes or use of spermicides. I can't stress the importance enough of doing an MSU, and I think it's important to do that with each infection. Do you want to know if it's a persistence or reinfection? And if you do an MSU and it's asymptomatic, you don't need to treat that. It's all more common with age. You don't necessarily need to treat that. I always like to do a vaginal examination to see if there's any prolapse, confusing things, and especially if there's atrophic changes, estrogen may really help. I don't usually do any investigations, but you can consider renal function, diabetes screening, or STI screening in young women, and only do imaging if really red flags: hematuria, pain, urosepsis, non-responsing, but routine imaging or cystoscopy is not required and shouldn't be done. When it comes to treatment, lifestyle is very important. Topical estrogen, I know I've talked about that a lot, but it really is quite important. I tell them, chuck out the applicator. Don't worry about the applicator. It makes it just awkward for them. Put a pea-sized amount in your finger and place it around the opening of the bladder. That's where you want it. Piprex, I really like. It is very cheap. It's very readily available and it can work really well. It won't treat an infection that's there, but it can be very good at acidifying the urine and preventing an infection from forming. Always talk about hydration, drinking more, post-coital voiding. It sounds basic, but people don't know this. Even wiping back the front, important to just link up. Cranberry products, mixed evidence in older populations, and especially tell them to stay away from cranberry juice because you don't want to increase their sugar input, but cranberry extracts can help. There's probiotics, D-mannose, ascorbic acid. I don't really use them too much. There's limited evidence, but no harm in trying them. Antibiotics are sometimes a thing they need to use, and I do like the patient-initiated. I will give patients scripts, but I usually give them a script with a urine jar and say, hey, if you're getting symptom infection, take a sample and start the treatment, because I want to get a sample beforehand because I want to know what we're dealing with. And if after 48 hours you're not improving, come back and see me. By that side, we should get the urine sample back and we should know what's going on. For patients that really have trouble, low-dose prophylaxis is okay. I usually recommend trimethoprim, a small dose, and usually for at least 3 to 6 months before you really review and see how they're going. Nitrofurantoin is what we used to use, but there's evidence of some hepatotoxicity and pulmonary toxicity. And finally, some post-coital episodes. Having a single dose within 2 hours can be useful. And I've had some patients actually take a dose of Hiprex within 2 hours and it seems more like it works. But there's other whatever kind of options work, I think is good. And trying to avoid antibiotics where you can is great. I don't prescribe the UTI, the vaccine. I haven't really seen so much of it work. I do have a colleague in urology that does prescribe it if need be. I think that's still, for me, an emerging option and something that may benefit some patients, but not commonly used in my practice. Okay, so it took a long time. A couple of take-home points. Incontinence is common, but undertreated. History is essential. Ask the questions. Bladder diary can be really useful. Always think an MSU. I love my pelvic floor physios, good for all types of bladder issues. Always think about lifestyle stuff. That might be all that's required to fix your patients. Topical estrogen is a really good treatment for a lot of things. And there's excellent non-mesh treatments for surgical stress incontinence for patients worried about the mesh. Thank you very much. Here is a QR code for my link again. Anyone on socials, LinkedIn, Facebook wants to get in touch, there's my details there. Happy to take any questions. I did make a few cases, which I know people love to talk about cases. So if there's time and you're interested, I have 4 kind of short cases if we wanted to go through. Unless Chris tells me otherwise, I can keep going. Are we running out of time or need to stop doing things?
Sure. I think we've got a bit of time. So there's a handful of questions, 8 questions or so. And I think we run till 9 p.m. Is that correct, Lydia?
That's correct, yes.
Yeah, so we've got plenty of time to do a few cases.
Okay. Well, I think people love cases usually. And these are cases that are real enough. They're based on things that I've seen. So I think it's worthwhile having a chat. So 4 cases here. Let's talk about the first case. This is a 74-year-old who comes for a second opinion CME. Well known to a urogynaecologist for several years. Long history of stress, predominant mixed symptoms of prolapse. Had urodynamics, very good workup, finding sensory urgency with a stable derusa and genuine stress incontinence. Yeah, had surgery 3 months prior, TVT, anterior repair, posterior repair, hysterectomy, sacral minus. But after the bladder has been worse than it's been. Started on Vesicare, started on Betmega, no imprudent, and had a plan for repeat urodynamics and was seeing myself. Thoughts about this case? Have a think about things. Feel free to enter some questions into the chat, but I will tell you what I did. I did an MSU and she had an E. coli UTI. I think this is like something sometimes we forget. People have this great workup, they do all these things, but we forget to sometimes go back to the basics. And maybe she's just getting a UTI that's causing these symptoms. And that's exactly what happened in this case. We were so focused because we're so far down the path of doing all this great treatments that a simple infection was all that happened. I also put on a bit of topical estrogen because there's always, as we get older, beyond the menopause, a bit of estrogen can really help the bladder function. And I found this was enough to just sort out this patient's problem. Case number 2 is a 63-year-old with worsening incontinence, history of recurrent UTIs with poor stream and incomplete emptying, but quite a bit of constipation with a bit of obstructed defecation and digitation. So what we refer to that is where obstructed defecation being trying to pass bowel motions but feeling something blocked inside and needing to digitate. So you'll have to often ask this to patients, do you stick a finger inside your vagina to push back the prolapse to help your bowels come out? And an examination of the large rectocele with atrophic changes to the vagina. So this case kind of focuses on the idea about the bladder and the bowels being related. If you've got a big rectocele or a big prolapse in the posterior wall, it can, first of all, pressure on the bladder and make it hard to empty. And when the bowel's not working well, the bladder doesn't work well. I love Metamucil. I tell my patients all try and be on Metamucil. Some really works well, others not. But it's a really good way of getting the fiber to get the bowels moving and improve the emptying. A pessary to reduce the bowel prolapse can make the bladder work better. it's often more challenging to use the products that help with, to use a pessary to help with bowel problems, but it can work. Again, vaginal estrogen to maintain that healthy urothelium and to consider those Hebrexal cranberry extracts. So this is the case really to talk about how important the bowel is in terms of improving bladder function, always thinking about that. Next case, we've got a 23-year-old student who's got some frequency, nocturia and pain, never had kids, long-standing history of painful periods. No severe surgery, no regular partner, but uses condoms, but drinks quite frequently and notices that worsens her bladder. I'll give you a moment to think about this case, but for me, and something that I'm often working with is endometriosis. So I often see these patients with bladder and endometriosis symptoms, and they often go hand in hand. And anytime there's any kind of period pain associated with the presentation, always think endometriosis, because can stimulate the bladder and cause troubles. A bladder diary is really important for these patients, and you'll see often how much alcohol or caffeine they're drinking and identifying why there might be some leakage. Very classic patient I've seen, you just stop them from binge drinking and their bladder improves. You can choose one or the other, a binge drink or not leaking. They've got to make a choice in what they want to do, and so you can't fix their leakage if they're having 10 drinks overnight and going out and wetting themselves. Bladder training can be useful, pelvic physiology can be useful, but you're also using the endometriosis treatments. The pill is a great option for a lot of them. Interstitial cystitis or bladder pain syndrome is a complex condition to treat, inflammation of the bladder that's unrelated to infection. Challenging one that I see quite a bit of, but unfortunately, it's more about lifestyle. I like dietary changes. There's a lot of medications you can use, but it's a challenging condition to treat, no talk all in itself. Finally, we've got our 34-year-old mum of two, recently had a couple of kids, can't leave the house because of significant leakage. Any activity, just walking, coughing, standing, sex, everything causes leakage. She's had a vaginal delivery, large babies required forceps, and does have some prolapse symptoms. I want to really focus on this case because it's the one that I see probably most of after me often talking passionately about it with people. These are the young women that have significant problems, and they're most are really affected by this. Every one of them should see a pelvic floor physio, try a pessary, do some exercises. It might make a big difference. I'm often talking to them about what to do about the next baby. Should you have a cesarean section? Is the damage already done? These are complex kind of discussions to have, and there's no right or wrong answer, but something that we need to talk about with patients. Often the damage is kind of already done with the first birth, and the next ones get easier, but you never know if you do need to have another forceps birth with a big baby. It can damage things further. We need to treat the conditions and treat the type of incontinence, but surgery is I really like to reserve it for once patients have finished their family. Although for very severe cases, I have done surgery before they finish the family, I would then recommend to have a cesarean section as a way to try and protect the repair, understanding that even a cesarean section can undo the work. So I really do try and focus on making sure that we're reserving surgery for when family is complete. And I do like to, from doing surgery, especially broach collar suspension, we'll do a bilateral salpingectomy as both a contraceptive and for risk reduction of ovarian cancer. So it's a common thing that I'll do to make sure that pregnancies no longer happen. That's me. So,
Thank you, Dean. That was a great talk.
no worries.
Got a handful of questions, if you don't mind.
Yeah.
Have the time to go through them.
Yeah, no problems.
So I might just read them out to you, and you can shoot away.
Yeah, I'm not sure how to see them.
First one is, in terms of history taking, your opinion of the bladder bother questionnaire as an alternative for us in GP land, a bit shorter, I believe.
So the bladder bother questionnaire, what I refer to there is literally me saying, with your stress incontinence, if you have to rate that out of 10, 10 being the worst, 0 being the worst, what would you rate it? And I don't think it's anything validated or any specific thing. I just ask it specifically my patients because I really like it to work out how much I should be doing for them, because they might be, especially with prolapse. I see that all the time. People have a prolapse. They've been told they've got a prolapse, they're freaking out about it. They come and see me. I've got a prolapse. What do I do? So how much does it bother you? So I didn't know I had it until someone told me, or I only know about it when I'm washing myself in the shower. The bother is 1 out of 10. I'm like, okay, go away. You're fine. It all depends on what you do is about their bother. So I usually get them to do that because it sometimes clears in my mind how much of an issue this is, more than how severe the prolapse is, more than how many pads they change. That's not a very clear one. So I really like it, but it's not like a special questionnaire. It's just what I do. There are a number of different questionnaires to consider, and some shorter ones, but that's my practice. Yeah.
Yep.
Hope that answers that.
So I think the next question is regarding measuring a post-void residual. Does the patient have to have an empty bowel as well when you do that?
Not necessarily. The thing is that often a full bowel will make it harder to pass urine. So if people are constipated and blocked up, their bladder won't work as well. The other thing I do see is patients try and pass urine when they're not full. And if you're not full, it's hard to pass. Any one of us will know that. You're not really feeling full and you try and pass urine, you won't pass very well. So I think, emptying the bladder can be tricky in these kind of clinical situations when your bladder might not be full, or your bowels might be full. So it's a bit hard to know exactly how accurate that test is. So yeah, it's a good question. Ideally, having the bowel empty is better. But if the bladder works regardless of that, then you're fine. It's only if the bladder is not working well, if they've got high residuals. And to define high residuals, I usually say it's a third of what you've emptied, right? So if you have 500 mils and you have 100 left inside, that's pretty good. But if you have 150 mils and you have 100 left inside, that's not so good. So it's about how efficiently you empty your bladder in relation to what your full bladder is. So yeah, it's a little bit of nuance to it, but to answer that, yeah, better to have an empty bowel.
And do you do that with a point of care device in rooms, or do you
I
send?
do. So yes, I have an ultrasound, as a bedside ultrasound, which is really simple. You can just put it on and see a big black circle. I don't even have a fancy thing. I just measure across in one axis and then swap it and do it again. And I just imagine the volume of a cube and then halve it. It's kind of really rough shape. There's lots of fancy equipment that'll have bladder scanners that I don't even have. You don't really need that. And you can just a bit annoying for the patients, but if you really want to know more detailed, you do an in-out catheter. All you need is to purchase a bit of lube and a single-use catheter, and you can be very accurate at how much left inside. Not as nice for the patient, but something you can do. So yeah, very easy to do as a point of care thing.
Sure. Is it a reasonable thing for us to just send someone to a radiology practice and get a bladder ultrasound, or is that?
Yeah, I think a renal scan is a very reasonable thing to do, and usually they'll do a pre and post voiding. The problem is you want them to go with a full bladder, but the problem is you don't know how long they will wait for there, and they're going to be busting while waiting. And it's a real stressful time for them. So it is useful. I don't do it routinely. What I don't really like is diagnosing prolapse on ultrasounds. I find that's a clinical diagnosis, and often they'll say cyst still seen on a prolapse. It's not really clinically relevant for me. I want to see how that is and define it and get them to valsalva and bear down and try different things. I think an ultrasound is an adjunct, but not necessary for that. Yeah.
Okay. I think the next question was partially mentioned in the talk, actually.
Yeah. I can see the questions now.
Curling, control your urgency or
Yeah.
confidence.
So there's this idea about the tibial nerve being linked to the bladder, right? Don't really understand how or why, but there's good evidence to support that percutaneous or transcutaneous tibial nerve activation can help bladder symptoms. We've got some physios that will do that as a treatment plan for patients. Curling your toes, scrunching your toes, or contracting your calves somewhat stimulate the tibial nerve. So there's anecdotal evidence that that is a good way of trying to defer an urge sensation. The trouble is you're better off contracting your pelvic floor, and sometimes contracting your toes can distract you from contracting your pelvic floor. But if you can do both, contract your pelvic floor and curl your toes, I think that can work quite well, specifically in that bladder training or trying to defer the urge that you're experiencing. So yes, it can work. But contracting your pelvic floor is probably better.
Probably better, sure. And then the next question's around beta-adrenergics. Is there new evidence regarding dementia risk
Ooh,
on those?
not that I'm aware of, but I'm always happy to be proven wrong. And I always say, I like a Socrates quote, there's one thing I know is I know nothing. And what we know is fact one day, tomorrow is absolutely garbage. So, I don't know that, I have to admit. I'm not aware of there being issues with mirabegron for dementia risk. But I'd be happy to be emailed about that question and I'll do a bit of research. I had just come from an international conference and that wasn't mentioned. But again, I didn't go to the whole thing, so that could be the case. So I'd be very interested for that person that wanted to reach out further. I might even do a bit of a lit review after this as well, in case there's something I've missed.
Fantastic. Okay. And then next question is on TENS machines that seems like some physios are recommending those.
Yeah.
The utility of those, because it seems like an expensive kind of intervention.
Yeah. So because there's percutaneous and transcutaneous tibial nerve stimulation. There's one that you actually put a needle into the nerve, which is more than TENS. That's the one that has some evidence to support use in bladder.
This is used on the tibial nerve, did you say?
Tibial nerve.
Not in the sort of pelvic region itself.
No, it's literally on the tibial nerve. Yeah. So they'll come in, they'll get a little needle injected into it. They'll have the session of the tibial nerve stimulation, and they'll go home. And that is also quite expensive because you've got to go into it. So a TENS machine is something you can take home and do. Again, I don't think there's a lot of evidence to do that, but anecdotally, if it helps and it's not surgery, then I'm okay with it. But you're right, it is a cost associated with it. And I think the evidence is not particularly strong, but it's very safe. I don't have any issues with people trying it. I've had people say it works for them, but I haven't seen convincing evidence of it. So,
Sure.
yeah, fair insult.
No dramas. And then there's a few questions sort of on a similar thing in terms of some patients, can't afford to access.
Yeah.
Are there any reliable resources we can sort of direct them to?
Yeah. So UGSA, IUGA, continence.org, Your Pelvic Floor Health. There's a bunch of different, and I think actually on my website at the end, I've got some links to some, I've recently updated it. I hope I put that in there. There's extra information about links to some resources. There is some pelvic floor exercises. And I think, definitely they're expensive. We have an issue in Sutherland where there's no public pelvic floor physio. They have to go to St. George. The wait time is 8 months, sometimes longer, to see a physio. And yes, worthwhile getting some resources. So yeah, UGSA, IUGA, continence.org, and yourpelvicfloor.com, I think it is, have some good resources. But again, my trouble is that some people, if you're doing it wrong, and you're making it worse, then it's I see it more, it's more often than I like when they say I'm doing it and they're just bearing down, like they're literally straining and making it worse. And I think you've been doing this the whole time. You've just been having effort towards making this problem worse. That's why I think at least one session of the physio can be really useful, just to guide you on the right track and then go on your own. But yes, check my website. There's some information there that can be very helpful.
Perfect. Okay. And then the effectiveness for pelvic floor exercises in general with fecal incontinence, is that? Yeah.
The sphincter is attached to the levator complex. Everything is linked together. So yes, fecal incontinence, urinary incontinence, strengthening one muscle can help other things, especially if there's weaknesses or damage to certain areas. You can strengthen other parts and it can help. So yes, there's never really a risk from that perspective. Where I see as a potential risk in overactive pelvic floor, so you've got patients who are doing too much, they've got vaginismus, they've got pelvic pain, and they're contracting so much that they're just tightened. That can be a problem. But otherwise, I wouldn't really be concerned.
Sure.
I see one other question there. Yeah, in the middle. That examination about leakages. Yeah. So I tell them to, so sorry to interrupt you, Chris. I just saw that question there. I tell them to, I say, I put my finger in the vagina. I put pressure on the posterior wall. I say, can you feel this? And I'll say, yes. I say, I want you to lift and squeeze my finger, like you're trying to stop yourself from passing urine, like you're trying to stop yourself from passing wind. Like, and you get them to go, say, yeah, that's pretty good, or not like that, try something different. You get them to try sometimes different things. Once you've got the right thing, say, yep, that's it, hold that, and then relax. Now I want you to do that again and hold for as long as you can. And just by guiding them through that way, you can say how they're doing the right exercises. And that's the exercise, that's the movement that they need to do to try and to contact the pelvic floor physio. So to pelvic floor exercises. So I do really feel like finger in the vagina is really helpful to guide them on that particular motion. Yeah.
Yeah, perfect. So I think there was a question about one of the third case with possible endometriosis.
Yeah.
The question was around sort of how we come to that diagnosis and what the sort of clues are. Knowing that the sort of gold standard diagnosis is a laparoscopy, and how do we sort of work our way through the intricacies of that presentation?
Yeah, anyone with pelvic pain with their period is not normal. So I always just like have that on the back of my mind. Anyone that has pain with their periods, think endo, right? Yes, there's an element of pain that's normal with the periods, but it should be treated with simple analgesia to the point that it goes away. And if there's any kind of dysfunction beyond that, always think endo, adeno. Adenomyosis is one that we're seeing more of, and I think it's going to be much more knowledge, and we're doing much more research about that. Very hard to necessarily diagnose, even at time of surgery, because you really have to look inside the muscle of the uterus, which you can't do at surgery. So really, I have a very low threshold to be thinking about endo in any young woman who has pelvic, dysmenorrhea. And I'm always thinking about that for a condition, just because I think I just see so much of it. And I've seen so many people that obviously have it and have been missed. So I'm always trying to think about that. I always tell my colleagues and GPs to just assume if there's any kind of pain, think about it as an option, because it can really change if you think about it early.
Yeah, sure. Okay, and then there were a couple more questions about devices.
So
it sounds like there might be a TENS machine that's actually inserted into the vagina and does intermittent stimulation for periods of time each day.
I've not heard of that. I generally, with those kind of things, I think that it's fine. Like, so maybe it sounds maybe a bit like the Emsella chair, where it's like a electrical stimulus directly into the perineum. I've tried it myself before. It's a bit weird. And so if you've got a device you're inserting inside the vagina for electrical stimulation to contract the pelvic floor, I think that, where I see these kind of things helpful is in patients when it doesn't matter what you do, they cannot contract the pelvic floor. It's probably because they've had damage during childbirth and the muscle attachments have torn and they've got nothing to contract on. They're the ones that I find that maybe there's some benefit. I'm not sure that's evidence-based, but that's when I'd potentially try these machines, try these things, see if they do make a difference. And I've had some patients that aren't able to contract the pelvic floor, do that for a period of time, and find they can contract the pelvic floor. It kind of like shows them how to do so and helps them in the future. So I think there's nothing to lose but the cost of that. It's safe as far as I'm aware. What I don't recommend is the laser therapy. So there's like vaginal laser that you can do that's marketed from anywhere from atrophy to stress incontinence to prolapse. There's good evidence that that doesn't work. And that's not electrical contraction. That's like CO2 laser and different other things. I don't recommend them.
Okay. And then there was another question around sacrospinal stimulators.
Yeah.
Thinking is probably in a similar kind of category.
So yeah, it's the sacral nerve stimulators.
Yes.
So that's actually a surgical procedure. I think about it as like a pacemaker for the bladder. It's something that I don't actually perform, but patients with refractory detrusor overactivity or even underactivity, they can benefit from that. And what will happen is they place a sample lead wire, so they do a smaller procedure to see if it works first, to test it out, and if it does work, they get a bigger surgery. And it can be helpful for bowel as well. So it is a surgery, because it's one that I don't perform, but I have colleagues that will if I feel like patients need it. But really, that is a last resort. If you've tried everything else and it's not working, then there's room for that as a therapy. Yeah, I think that's what, yeah.
Sure. And we've got one last question on endometriosis.
Yeah.
Is a pelvic ultrasound a useful test for diagnosis? And can you have a transabdominal scan only and get any clues from that as a test?
So the reason why I'm a big fan of ultrasound, just in general, but also for endo, is because you can put a transabdominal probe in and see two massive endometriomas stuck together, and you can diagnose stage 4 endo. So there's no harm in doing so. The problem is if you don't see anything, what do you make of that? If the transabdominal probe doesn't really show as much as a transvaginal probe can, a transvaginal probe shows as much as the skill of the user. So it's a lot of different variations in skill and experience of people using the probe. And it's a very dynamic process where you see how things move, see how the bowel slides, see how the move, and it's very difficult to do well. In patients that you can't use a vaginal probe where they're not being sexually active or for whatever reason can't, that's where I often will get a pelvic MRI. There's now new item numbers that make that a rebatable item for specifically pelvic endometriosis. The problem is the reporting is also of mixed quality because people aren't really used to reporting on endometriosis, and there's not specific centers with experience with big numbers and reporting on it. So it's, again, difficult to get it really well. And I work in a place where we do a lot of endo surgery, and so we've got our specific people that we send for imaging and send for either MRI or ultrasound, and we do, discuss about how good what they saw was what we found in surgery. So, there's good feedback there, but a lot of the time it is quite inaccurate. Never harmful though, because I think that is always value in getting it done. But the point is that you can see so much more than your finger can feel, right? So if you're doing an examination with a vaginal probe, that shows you so much more than you can feel with the finger. So if you're going to do an internal examination, use a vaginal probe and get an ultrasound to see what's going on. It will provide you so much more information. Well, if it doesn't show endo, they could still have endo. That's just the thing to think about. Yeah, but still very useful. Yeah.
No problem. So that's it for all the questions. There was
I see something about a
one
50
person has
double
come through with a literature reference with a mirror background dementia
Please,
question. So it looks like there's an article for us to all read.
Awesome.
Joe Su et al. Urology Focus 2024 March study. So that might be one for us
Thank you.
to look up after.
I'm going to copy and paste that right now.
Yeah, fantastic. And Lydia has posted the link to your website in the webinar chat for anyone that with the links that you mentioned before for any participants that wanted to click on that.
Great.
So thank you again, Dean. That was a great presentation and really appreciate your time and expertise.